very good morning to each one of us. Today is another important day, and today Mumbai Hematology Group presents to you another interesting webinar on management of sickle cell disease. I was speaking to our program director, Professor Dr. M.B. Agarwal, sir, and I just wanted to congratulate him. I think 300 plus webinar and so many DNB students owe it to this group for making their DNB successful. Nothing can't be much more pleasing than this. It's my honor and privilege to introduce the gentleman on the screen, Professor Dr. M.B. Agarwal, sir. We all know him very well, teacher of teachers, an academician and a clinician par excellence, attached to prestigious Bombay Hospital and also at Leelavati Hospital, president of Mumbai Hematology Group. So we are extremely fortunate to have you, who has enriched us by collaborating with stalwarts in hematology across the globe and bringing them on virtual platform every weekend. Thank you for sparing your time, and thank you. May I request you, sir, to take it forward from here.
Thank you, Dr. Manoj, for those kind words, and good morning to one and all. Today, our guest speaker is Professor R.K. Jena from Cuttack. He will be lecturing on management of sickle cell disease in 2023. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Kapil Garg from Jaipur, our guest speaker, Dr. R.K. Jena from Cuttack. All our discussants were themselves eminent hematologists or pediatric hematologists, and you participants for sparing your Sunday morning, afternoon, or evening, depending upon which part of the world you have connected from. Glimpses of next weekend webinars. Saturday, 19th August, 7 p.m. IST. Dr. Tufan Kanti Dolai from Kolkata will be speaking to us about pancytopenia. And the next Sunday morning, 11:30 a.m. IST, Dr. Priyanka Chauhan from Lucknow will be speaking to us on ITP. Discussions today include very important persons from India all across, and they have been put up alphabetically here, and I'll briefly introduce them to you. We have Dr. Amit Khurana from Surat, Dr. Anand Prakash from Bangalore, Dr. Ashok Rajoria from Gwalior, Dr. Malikarjun Kalashetty from Bangalore, Dr. Manoj Toshniwal from Aurangabad, Dr. Pujitha Baireddy from Hyderabad, Dr. Radhika KK from Hyderabad, Dr. Sanjukta Rai from Bangalore, Dr. Satish Kumar A from Bangalore, Dr. Sitharam Anandram from Bangalore, Dr. Shilpa Prabhu from Bangalore, Dr. Suma TL from Bangalore, Dr. Suman Jain from Hyderabad, Dr. Sunil Bhatt from Bangalore, Dr. Sumit Lokwani from Indore, Dr. Tejaswini Gudibande from Bangalore. It's time to introduce our guest speaker, who needs no introduction whatsoever, to the audience from India and probably from the rest of the world as well. Professor R.K. Jena is MD, PhD, hematology. He's hematologist, hemato-oncologist, donor transplant physician. He's professor and head department of clinical hematology at the prestigious SCB Medical College and Hospital, Cuttack. He did his MBBS from SCB Medical College, Cuttack in '83, followed by post-graduation general medicine from Vimsar, Burla in 1988. He returned to SCB Medical College for his PhD in clinical hematology, and he completed the same in 2001. He is a fellow of Indian Society of Hematology and Blood Transfusion. He has received advanced training in the management of thalassemia from Cyprus, courtesy TIFF, and bone marrow transplantation from University of Minnesota and the VTP program by Ash. He was instrumental in establishing the BMT unit in the Department of Clinical Hematology at the SCB Medical College and Hospital, Cuttack. He has over 50 papers in peer-reviewed international and national journals. He received the Best Research Paper Award in the Annual Conference of API 2001, Second Best Research Paper Award in the National Conference of Pediatric Hematology Oncology 2000, Kolkata, Professor M.C. Mishra Memorial Award of IMA for Best Research Article 1995, and Professor M.C. Mishra Memorial Award of IMA for the Best Case Report in 1996. He was a member of the various policy formulating agencies like the National Cancer Guideline 2019 for formulation of protocol for adult hematolymphoid malignancies, NHM Guidelines 2016 for hemoglobinopathy for Ministry of Health, Government of India, Committee for the Preparation of Guidelines for Hemophilia by Ministry of Health, Blood Cell NHM Division, Government of India, and the committee member for Blood Task Force NHM, Government of Odisha. He is a member of the American Society of Hematology, Indian Society of Hematology and Blood Transfusion, FOCON, ICON, API, and IMA. He was president of ISHBT for the year 2019-20. He will be lecturing on management of sickle cell disease in 2023. But before that, let me introduce a very special guest today who will be inaugurating our webinar. And that's my friend and colleague, Dr. Kapil Garg. He's our chief guest for the day. Dr. Kapil Garg is once again very well known to the community all around in the field of pediatric hematology. He's senior professor and head, Pediatric Hematology Oncology Division at SMS Medical College, Jaipur. He's member, Research Review Board, SMS Medical College, Jaipur. He's a recipient of the Outstanding Faculty Award from SMS Medical College. He's principal investigator in 7 clinical trials and projects, which include ICMR project, various vaccine trials, and 2 global drug clinical trials. Rich organizational experience, had been on many posts, including president, IAP state and city branches, ex-editor of several indexed medical journals, author of over 25 peer-reviewed papers in the international and the national journals. I request him to inaugurate our today's webinar and give some words of wisdom. Over to you, Dr.
Thank you very much, sir, for the kind introduction and for inviting me as a chief guest in this prestigious Mumbai Hematology Group meeting. A very warm good morning to all the participants. Sir has asked me to give a speech to inspire young fellows to take up hematology oncology as a specialty. But I think the fellows who are associated with sir do not need any kind of inspiration. By just seeing his zeal, dedication, sincerity, and hard work, it should be enough to inspire them. He's a role model, and even I take inspiration from him. But nevertheless, because he has asked me to do so, so here I am. I personally find practice of hemato-oncology really interesting, particularly hematology. I think there is no other specialty where simple tests as simple as CBC gives you so many clues. It is so satisfying when you diagnose a patient of leukemia who was getting treated as rheumatoid arthritis from last many weeks by such a simple clue that he or she had out of range lymphocytosis in his or her first CBC, which nobody noticed. Similarly, many leukemia patients are getting treated as chronic ITPs, again, lymphocytosis and mild anemia unnoticed in the first CBC. Then MCV decreased out of proportion to anemia. You know you are dealing with thalassemia trait. By seeing IPF values, you can say whether the cause of thrombocytopenia is increased destruction or decreased production. By 2 very simple tests, LDH and bilirubin, you can differentiate between aplastic anemia and megaloblastic anemia. The 2 diseases having great difference in prognosis. So all the diseases which I have mentioned, they are fairly common, and only hematologists can diagnose them so easily, and you really enjoy doing this. Then there are complex cases too, where despite extensive investigations, you are not able to reach a conclusion. And here you have to apply your mind so hard that you will never develop Alzheimer's disease. Jokes apart, the hemato-oncology specialty, I think, is also very rewarding too, because of new conditioning regimens for transplants and targeted therapies in cancers. The prognosis of majority of hemato-oncological cases has improved a lot, and it is so thrilling and gratifying when you make someone cancer free. If you see commercially also, I think cases of hemato-oncological problems are increasing at a very rapid pace. And because of government schemes and increased penetration of insurance schemes, I think majority of people are now able to take treatments, which that was not the case earlier. So it is a very upcoming branch. So when you embark on your journey, always remember that behind every medical condition lies a profound human story. Every time you face a clinical challenge, it symbolizes a person with dreams, hopes, and loved ones. By your commitment and hard work, I think you can rewrite the chapters of your patients' lives. I will give you my own example. Till 2010, all the oncological cases coming to my institute were referred to Delhi. And by that time, I was settled with a job as faculty in this prestigious institute, as well as I had a good practice. But still, seeing the suffering of these patients posed me to think that why can't we treat these patients? Though I was not very keen in taking up oncology as a specialty. So I went to New Delhi, AIMS, and took a short training in pediatric oncology and started treating these patients at my institute. Initially, I faced many challenges because I was alone. There were no dedicated fellows or residents. Drugs were limited. Investigation was very slow. Patients were very sick. And there was no support from the government. But somehow I managed and continued. Of can kids came to me and asked. Rest is history. They provided me with social worker, teachers, etc. And as our numbers grew, 12 more NGOs joined me. And we started providing absolutely free treatment to our patients, majority of which were children of laborers and street vendors. So if you work transparently and honestly and sincerely, I think there is no dearth of funding. A specialty service which I started on very few beds is now so big that recently my hospital has provided me a 100-bedded dedicated daycare, hemato-oncological daycare. Then there are few tips from my side for your practice. Be empathetic towards your patients, because empathy is not just a desirable trait for the doctor, it is an essential one. Medicine, as we all know, is ever evolving. So stay hungry for knowledge, seek mentors who inspire you. Remember, the day you stop learning is the day you stop growing. And collaboration will be your greatest ally in your journey. Recognize the strength and power of interdisciplinary coordination or cooperation. Connect with your fellow hematologists, share your ideas, engage in dialogue and debates, because the power of collective intelligence truly thrives through collaboration only. And remember that the true measure of success doesn't lie in accolades or titles. It lies in the lives we touch and the positive changes we bring. But in all this, never forget to take care of yourself, because the journey of the doctor is very demanding, both physically as well as emotionally. So always take time out for getting recharged and rejuvenate, because 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institute, 80% of the patients who come to my institu if you remain well, then only you can take care of persons who rely on you or patients who rely on you. So, in conclusion, I think embrace the challenges and you will have your own ups and downs. But remember that the stars shine the brightest during the darkest times. So, thank you very much, and may your journey be filled with purpose and success. Thank you.
Thank you, Dr. Kapil Garg, for that wonderful speech and the messages that you've given. I was a visitor to his wonderful, large hospital, the pediatric wing. As he mentioned, this is one of the largest I have ever seen. Virtually a floor devoted to one disease, and it took us around that whole place, and the time fell short in seeing the whole institute. What a wonderful job he is doing. Congratulations for the achievements and, of course, the help that you are giving to the poorest of the poor, the people who have been deprived of their health and resources. And thank you very much for
Thank
being
you.
with us, sparing your morning,
Thank you, sir.
very important part of your life, for giving this message. Dr. R.K. Jena is facing a connectivity problem, and he will be with us in couple of minutes. And we are going to utilize these couple of minutes to give you certain messages. I see Dr. Malikarjun is here. Dr. Malikarjun.
Good morning, sir. Good morning, sir. How are you, sir?
I'm fine. Would you like to introduce the next week's meeting that you have?
Yeah, yes, sir. So, thank you for the opportunity, sir. We at Bangalore are having annual CME from Karnataka chapter of Indian Society of Hematology and Blood Transfusion. All of you are welcome, sir. Thank you, sir.
Venue?
Sir?
Venue of the meeting?
Yes, sir. It's at the Taj, sir, Trinity Circle.
Right. So that's the venue, and the timing?
It starts at 9, sir, and all the way till the evening, sir. Yes, sir.
It's the whole day, 9 o'clock onwards.
Yes, sir. Yes, sir.
Those of you who are from Bangalore and who are listening today, I suppose, Dr. Malikarjun, everybody is welcome?
Yes, sir. Yes, sir. Of course, sir. More than welcome, sir.
So this will be a very good CME organized by Dr. Malikarjun on various aspects of hematology. And please, if you have time to spare, come and educate yourself in Bangalore, Hotel Taj, whole day. Fine. So that was one message. Second, yes, Malikarjun.
Thank you, sir. Thank you so much, sir. Thank you.
My pleasure. I would like to introduce, probably all of you are aware, but I'd like to introduce you to the midterm conference of Mumbai Hematology Group that is coming up. It is the last 2 days of September this year, that is 29th and 30th of September and 1st of October. 3 days conference. It's weekend, Friday, Saturday, Sunday. Ganpati Visarjan Day is there in Maharashtra on 28th of September. So this is right after that. And as you know, 2nd October is a national holiday. Yeah, thank you so much, Kalpesh. Here is the brochure front page. So as you see, that this conference is not only midterm conference of Mumbai Hematology Group, but it also has an update from the 24th annual conference of European Hematology Association, which was in June this year. And we also have the best of 17th ICML, the International Conference of Malignant Lymphoma, which was held in Lugano, once again in June this year, together with, of course, the midterm conference of MHG. The venue is exactly the same where we had the best of ASH early this year in Jan, and you loved the venue, the Learning Galaxy, Urmi Estate, which is just opposite the Hughes Peninsula Business Park, which has become extremely famous in medical and paramedical community. It's in Lower Parel West, and it's in Mumbai. We have international guest speakers. They will be giving certain very important lectures. Biju George from CMC Vellore is at the present in Abu Dhabi. He is not only giving guest lecture, he is also our guest of honor for the inauguration. And we have few more. Dr. Ranjana Advani is very, very well known to all of you. She is our own, having the flag of India high at Stanford University, California. And she is giving a large number of lectures on Hodgkin, non-Hodgkin lymphoma, and also carrying out some case discussions. And then we have Professor Maria Scully, the big name in the field of hemostasis and thrombosis from London. And she will be speaking on our pet subject of thrombotic thrombocytopenic purpura, atypical hemolytic uremic syndrome. She will be speaking and also covering the discussion on cancer-associated thrombosis and case discussions. And then we have Dr. Maria Victoria Mertes from Spain. You must be aware that the conference of multiple myeloma, the international conference, is taking place in Greece, and it is ending on 28th of September. And the same night, she's traveling to join us on the next day, and she will be giving 5 lectures on whatever will transpire in that annual conference of Myeloma International Group, and cover the subject of myeloma extensively. And then we have Dr. Zurzek from Poland, who has researched on T-cell lymphomas throughout his life, and he will be sharing all his experiences about T-cell lymphoma, and also once again discussing cases of T-cell lymphoma, how tricky they can be. So that's our international faculty. We have 100 plus national faculty, and this is just a glimpses. Yes, Kalpesh, you can move on. I will show you just one page that how this conference is organized. We have hall A, B, C, and D, and that's right, A, B, C, and D. And in fact, on day 2, we have hall E also, which was introduced just recently because of the demand of people who want to participate in this meeting. On each day, we have 4 sessions. Session 1, 2, 3, and 4. 2 are pre-lunch, 2 are post-lunch. There are formal lecture presentations. There are sort of panel discussions, case presentation, and various other kind of activities. You have your usual coffee and lunch break, and we end somewhere at about 6 o'clock, beginning at 9:15 every day. 4 parallel halls, and going on for 3 days. We are covering almost about 120 subjects. That's the registration details. Those who are members of Mumbai Hematology Group or associate members of Mumbai Hematology Group, up to 15th of August, the auspicious day, the registration is free. Although you have to register, and the registration is by just clicking on this link that is given, and this is available at the website of Mumbai Hematology Group, and the details of website of Mumbai Hematology Group is in my signature. Any email from you, at the bottom of that, you have the website of MHG. There's no password. You just click and you will be at the Mumbai Hematology Group website. And you have this link to register for this conference free if you are MHG member. And if you are not member, a student, just a meager sum of 500. Not only the academic session of the 3 days, you also have all the associated things free. Other seniors, 1,000. Trade registration, 2,000, and international delegates, 50. Then, of course, it slightly goes up to the end of August, and then from the September beginning, the spot registration. So make use of, if you're a member of MHG, make use of this free registration. If you're not member, very small amount for huge academic session. We have a traveling fellowship for the students belonging to institutes. This traveling fellowship is of rupees 10,000, and you are eligible for it if you submit a paper for either poster presentation or oral presentation. So the registration for the conference for you becomes free. You have the opportunity to put up a poster or do an oral presentation, and of course, you get 10,000 to cover your travel expenses. There are many other ifs and buts which you can see at the site of Mumbai Hematology Group. We already have 300 plus registrations, and I expect many of you will join because we're still 1.5 months away. So that was the message about the midterm conference of hematology that we have on behalf of Mumbai Hematology Group. I yet do not see Dr. Jena joined us. He's facing a serious connectivity problem. He's feeling miserable about it. He has messaged me repeatedly that any moment he will be with us. Within the group, if anybody wants to share anything, you are most welcome. I take this opportunity to thank my friend Dr. Amit Khurana, who has very successfully conducted a large number of webinars and is going to help me in conduction of various webinars in time to come as well. This has given me liberty of decreasing my some responsibility, and I'm extremely grateful to him because he has done it so willingly, so aptly, and so carefully. No mistakes, wonderfully. In fact, sometimes I've heard you are doing much better job than what I have been doing. So thank you very much, Dr. Amit Khurana.
Thank you so much, sir, for giving me this opportunity, sir. All credit goes to you, actually.
He is also anchor for our midterm conference of hematology, when the main hall, Hall A, will be anchored by him from morning to evening on all the 3 days. So he's a huge help for the hematology.
Thank you, sir.
Yeah. Sunil Bhatt is here with us. Sunil?
Hi, good morning, sir. Good morning.
Good morning. Sunil, you are doing a marathon job of transplanting these hemoglobinopathies and thalassemia. Until Dr. Jena joins us, can you share some of your experiences and any messages?
Sir, not really, sir. I think there are many other groups, and I think it's been exciting. Last 5 to 7 years has been very exciting. In various aspects. One, I think, has been, the outcomes of matched sibling donor transplants have improved tremendously, and also with the support from the Ministry of Health and Coal India, I think many speak. I think more than 400 transplants through that initiative have happened through in various institutions. So that has been one, I think, a great, I would say, success story in hemoglobinopathies, especially thalassemia transplants in our country. Second, of course, is that the unrelated donor transplants are also have improved in outcomes, and partly because of better, I would say, donor selections and better high relational typing matches, better understanding of the GVHD and GVHD prophylaxis. One of the things which I can share with everyone is that we have been using post-transplant cyclophosphamide for the mud donor transplants for thalassemia and others also, and we see quite dramatic reduction in the graft versus host disease with the post-transplant Cy in mud donor population patient group also. So that's something which we are excited about, because GVHD has always been a concern with a PBSC graft in a mud donor transplant. So that has been the second, I would say, highlight of in the last few years. Also, better access, thanks to our own, pharmaceutical industry in the country. We do have now access to, the reducing toxicity conditionings like triosulfonatide, which is made here cheaper than the original brands, and I think we are able to now use that for higher risk thalassemia patients as well as older patients, and that also, of course, has improved outcomes the recent years. The last has been, progress in the haploidal transplant programs, and I remember it used to be a debate 5, 6, 7 years ago. A lot of ethical questions being asked whether it's ethical to do a haplotransplant or not in a thalassemia major. But I think over the period of time, we have all evolved, learned, and improved the outcomes there as well. And in fact, when I was compiling our data, which we presented in a couple of meetings, and also now is under review for publication, the outcomes of haplotransplant thalassemia we do with 2 techniques with alpha beta depletion is in the range of 89-90%. So which is a huge, I would say, progress over a period of time, and 90% of the patients with T cell alpha beta can be cured with haplotransplant with thalassemia. And so with post-trans cyclophosphamide is also another way where we do haplos in thalassemia. Of course, 3-4% inferior to T cell alpha beta in our experience, but also 85 plus patients can be cured. So I think these have been some of the highlights of hemoglobinopathy transplants. And I'm sure that times to come, things are gonna get better, and probably more and more patients who wouldn't have had opportunities to undergo these chemo treatments will be able to access those treatments. So that's from me, sir.
Thank you. Thank you, Sunil. That was a wonderful knowledge sharing, the experience sharing, the marathon amount of transplants in hemoglobinopathies that you've done at your center. And I'm sure everybody in India is very, very proud of you. We also have Dr. Suman Jain with us. Suman, you are there? She's organizing a very important conference on this field in October. Will you like to share something about this conference and the great work that you are doing at your center? Yes. Dr. Jena has joined us. Dr. Jena will just take 2 minutes of speech from Dr. Suman Jain before you start.
Yes, sir. Yeah. So we are having, I want all of you to join us. It is on 7th October, our second national conference for the management, cure and aware, and also the newer treatment and basically the prevention. So this conference is basically all those things. The first from 9 to 6, it will be a scientific session. And from 6 o'clock to 9 o'clock, there will be a cultural program done by our children. Thank you.
And it's an open invitation to everybody who wants to join, right?
Yes. Yes.
Sure. So we will send you the details of the venue and all other details that Suman has shared with you. And please join her and make that meeting a great success. So now we go over to Professor Jena. Thank you very much for putting all the efforts and joining us finally. We have already introduced you, so I will not introduce you again. You can straight share your screen and go ahead with your lecture.
So, sir, thank you, sir. Good morning, and my apology at the outset. There was a sudden power cut, and we waited since I again rushed to my residence. In between, I heard that the power has been restored. Again, come back to my department, and I could able to join. That's the things which sometimes are beyond our control. And at the outset, I must extend my sincere thanks and my gratitude to Professor N.B. Agrawal and the Mumbai Hematology Group for giving me this wonderful opportunity to speak on a very important topic on management of sickle cell disease in 2023. I believe I am audible, sir. Hello. Hello, sir. Am I audible?
You are audible. Your screen is visible. Go ahead.
Okay, sir. This talk is always dedicated to the sickle cell community, as I believe they are deprived of many of their fundamental rights. And so the flow of the presentation will be prevalence, pathophysiology, clinical presentation, diagnosis, Indian Arab haplotype, hydroxyurea, iron chelation, and pregnancy unmet need. So this is the distributions of the sickle cell disease around the globe. This is African countries, Indian subcontinent, Middle East, so on. If you look at the Indian distribution, though the average incidence varies from 5 to 40%, this figure is a world figure. I am sure it will be changing at the time as the studies are going on. But however, those sickle cell are more prevalent in Odisha, Chhattisgarh, Jharkhand, Gujarat, Madhya Pradesh, and Kerala, Tamil Nadu. These are the few states where the sickle cell disease is more common. But I believe that sickles, because of the population migration and intercaste marriage, now sickle cell disease is seen across the country, across the caste, across the economic class. No, though there is certain areas where the prevalence of the sickle cell disease is much more high. The sickle cell disease in India is a major health problem, but the gene frequency varies from 5 to 40%. Socio-economic burden is huge. It adversely affects the national productivity, infant mortality rate, maternal mortality rate, and the national registry has just started. In the last 1 year, only the National Sickle Cell Mission has been started, and there is a centralized registry where all the newly diagnosed sickle cell thalassemia, hemoglobin disease are entered into that portal. Pathophysiology, as you know, it is a single amino acid substitution at the position of the 6th position of the beta globin gene. The adenine is substituted with thymine. That gives rise to the corresponding amino acid chains. Is glutamine is replaced by the valine in the beta chain. That's the way we call it as hemoglobin H is called alpha 2 beta 2 with a mutation at the position of the 6th position of the globin chain, where the glutamine is replaced with the valine. And as you know, the hemoglobin S, the sine qua non pathophysiology is it gives rise to the increased polymerization because of this single mutation. Pathophysiology, as you know, it is confined to the red cell. That is abnormal to the red cell. It has a multifactorial, though there is only one amino acid substitute, but the pathophysiology is really confined to multiple factors. Red cell abnormality, neutrophil, platelet, endothelial cell activations. It's a chronic inflammatory, so it's a lot of inflammatory pathways has come up. And plasma constituents, there are many procoagulants and anticoagulants alternations in a way that it becomes an hypercoagulable state. So pathophysiology sickle cell disease is multifactorial, as you know. This has been depicted, as I already told you. The abnormality lies in the endothelial cells, RBC platelet, because of the increased adhesiveness. It's a chronic inflammatory condition. So many inflammatory markers are released. Therefore, it leads to hypercoagulable stage, as you know, because of the dehydration and other factors and other predisposing factors. And because of this abnormal hemoglobin structure in the beta globin gene mutation, hemoglobin S, that leads to polymerization and hemolysis. Instead of RBC staying for 120 days, they are destroyed less than in 20 days also. So there occurs hemolysis, increased adhesiveness. It's a chronic inflammatory disease and it's a hypercoagulable stage. All these factors lead to the pathophysiology of the sickle cell disease. Precisely, as you know, it's a beta globin gene mutations that leads to the hemoglobin S polymerizations and vaso-occlusion, as you know, that leads to vaso-occlusive crisis. And there can be even the subclinical vaso-occlusion also in various organs also. Though the clinical, they don't present as a vaso-occlusive crisis, but as there are subclinical vaso-occlusion into the different organs, so there can be organ damage also. Recurrent subclinical vaso-occlusion of the vessels supplying the organs, that leads to chronic organ damage, means any organ can be affected. As I told you, there occurs, it's an hemolytic condition, so there occurs hemolytic anemia. And they are prone for infections, and there is a vasculopathy because of the various reasons. So recurrent vaso-occlusive crisis, chronic organ damage, chronic hemolytic anemia, infection and vasculopathy, presenting from childhood with a history of the positive history in the family history, that essentially comprises the pathophysiology of sickle cell disease. As you know, there are the sickle cell disease because of the various epigenetic factors. They are not single category. We have a, depending on time, we have a 5 types of the haplotypes. One is Cameroon, second is Senegal, Benil, Bantu, and Arab Indian haplotype. Sorry, it's not visible here, Arab Indian haplotype. Our Indian populations or the Indian patients, along with the Middle East, they belong to Arab Indian haplotype. So there are 5 types of the haplotypes with a distinct and clinical features and pathophysiology also. So this is the vascular phenotypes of the sickle cell disease. You know, on the one end of the, it is a wide spectrum of the clinical presenters. On one end, you have a hemolytic phenotype where features of the hemolytic anemia is much more high, like you have a low hemoglobin level, you have a higher LDH, higher unconjugated bilirubin, you have a decreased haptoglobulin, and these are the complications: pulmonary hypertension, leg ulcer, pre-aborigine strokes. These are common features of an hemolytic phenotypes. On the other end of the spectrum, you have a vaso-occlusive phenotype where hemolytic component is less predominant. The predominant clinical presentation is hemolytic anemia, where you have a lot of vaso-occlusive complications and hemolytic features are less. On the other hand, you find many of the patients which in between this spectrum, with some features of the hemolytic anemia, some features of the vaso-occlusive crisis. So the spectrum of the clinical presenters is wide, starting from one end to predominating hemolytic phenotype to other end of the predominantly vaso-occlusive phenotype. In between, many combination of the both the features are there also. Alpha thalassemia co-inherit and swings the pendulum from left to right. So it swings towards the vaso-occlusive phenotype. That's exactly what happens in the Indian haplotype. In Arab Indian haplotype, for our patients, they are purely a vaso-occlusive crisis. As you know, the alpha thalassemia co-inheritance is much more higher. So most of the patients are of this phenotype, vaso-occlusive phenotype, though there could be some combination of the vaso-occlusion and hemolytic anemia component also. That essentially explains the clinical spectrum of the sickle cell disease. The factors responsible for this clinical variability, as you know, the high hemoglobin F level, which is the common in Arab Indian haplotype, gene cluster type haplotype, I told you just 2 minutes back, alpha thalassemia mutations, environmental factors like social class, infections, diet, climate. These are the factors or known factors. However, we do not know in many cases what could be the possible reason. In that possible case, to explain the severity of the disease. So these are the summary of the variable or the factors which can alter the clinical presentation. Just a few slides. It was a long back study in 86. My teacher Bishikam Farman Burla. There is a important difference between the Indian haplotype with African haplotype. Here the alpha thalassemia gene mutation is much more common in our haplotype. Look at the hemoglobin F level, median level. It's much more higher in comparison to the African type. The splenomegaly incidence, severity, persistence of the splenomegaly is very high in comparison to Arab Indian haplotype. Similarly, the phenotype, as I told you just 2 minutes back, is predominantly of a viscoclusive phenotypes, whereas it is a hemolytic type in African type. Iron chelation and regular blood transfusion, which only can be seen in 10% of cases in our haplotype, vis-a-vis with 30 to 50% with the other haplotype. So these are the few important point of differentiation between our haplotype with the African haplotype. It's really surprising that you, as I told you, that the sickle cell disease is that is the only simple misspelling. There is a only mutation in one amino acid, single nucleotide substitute. That gives so much multifaceted pathophysiology with a remarkable variable in phenotypes. That's probably one of the biggest mysteries of medical science. With a simple misspelling, the genetic misspelling, how come it is such a variability, not only the pathophysiology, in many variable phenotypes also. So sickle cell disease is a perfectly the poster child to explain between the dichotomy between the science and sociology. There is a huge social variations, even the science remaining same. There is a lot of variation, means the complication, morbidity, mortality, like so life expectancy, so much of variability is there in sickle cell disease. No other disease will find such a variability. And so far the health disparity is concerned, is one of the diseases where there is a greatest health disparity. So sickle cell disease is a poster child to explain these two paradoxes in our medical history. So variable phenotypes, health inequality are greatest challenges our sickle cell community are now facing. The clinical features, just in principle, are to have evidence of the chronic hemolytic anemia which starts from childhood and with a positive family history, as the recurrent infections, acute complications include vaso-occlusive crisis, which are called as a hand-foot syndrome, pain-foot crisis, brain damage, acute chest syndrome, and priapism. You can have a aplastic crisis, you have a sequestration crisis, which can be splenic or hepatic. Then chronic organ damage, as I told you, there could be the clinical or subclinical without any symptom also, subclinical occlusion of the vessels supplying the organs. So that can look, every organ can be affected. The most common is you have a leg ulcer, gallstone, bone complications, renal failure, cardiac failure, neurological, and endocrine complications. So these are the few principles or the guidelines or the few important features of the clinical features. So this is the common complications of adult sickle cell disease, as it can start from the head to the brain to the toe. The brain can be affected both in infection, hemorrhage, eye is affected, heart, lung, and pulmonary hypertension, intestine, bone complications are typical, skin ulcer, priapism. These are the very common and very known complications of sickle cell disease. However, every organ can be affected. Main causes of the mortality is infections, acute chest syndrome, stroke, renal failure, pulmonary hypertension. These are the 5 main causes of the mortality. Now I'll go through the real case stories of 5 to 6 cases, how we are going to manage in 2023 and what are the changes which have occurred. A female child, 2 years old, 15 kg, with history of recurrent polyarthritis, both hand and ankle since 10 months of age. She has a paler splenomegaly. Investigations reveal hemoglobin S is 84.6, F is 12.1. Other parameters are within normal limits. So diagnosis is very clear cut. It is a sickle cell homozygous with hand-foot syndrome. Why I bring this? It was in 2002 where hydroxyurea was never approved in a pediatric age group. But we have used, I myself personally in Odisha, I have used hundreds of patients of pediatric patients, even if it was not officially approved, because there was no other things were available. So there was the only thing available Even if it's a capsule form of 500 milligram capsule, I have broken the capsules and divided the powder, and it has been given by the mother with an anticipating 10 to 120 milligram per kg of the body weight, and it works. Then subsequently what happened, then come the very iconic studies, your baby, it's a landmark study, first time in the infants baby health study. They took both symptomatic and asymptomatic, and they have used less than 2 years of the patient's age group. They have given a fixed dose of hydroxyurea, about 20 milligram per kg of the body weight. What they found in a hydroxyurea group, the total painful events, dactylitis, acute chest syndrome, and the incidence of the hospitalization is reduced by significantly in comparison to the placebo group. So that another in a subset analysis, what they did in an asymptomatic groups, they again compare hydroxyurea with placebo. They have given hydroxyurea even without any symptom. What they found that the incidence of the subsequent painful dactylitis, acute chest syndrome, and hospitalization and blood transfer requirement is significantly less in comparison to the one placebo. So what this baby health trial has shown that it is not only effective in all the children up to 2 years age, even in asymptomatic patients also, it can be very beneficial. From that, hydroxyurea is approved in children in 2017, even if we have used much more earlier, even before 2002, so we have used this drugs. Case number 2 is a female, 23 years, 45 kg, and she is a chartered accountant by profession. Her sickle cell is 72.3. Hemoglobin F is 20.7. The presentation was a recurrent vaso-occlusive crisis since July 2014. All the investigations were all the biochemical and electrolyte, pulmonary function, cardiological, and hip joint evaluation were within normal. Here, the issues to be discussed is that with these features, how to differentiate between sickle cell homozygous and sickle beta thalassemia, management, hydroxyurea, how to go for the red cell transfusion and iron chelation. So this is a picture of the capillary zone electrophoresis, which I have shown it, not of that patient. Here hemoglobin S is 62.6, hemoglobin F is 28.9. Here you find many of the patients of our sickle cell disease of a similar hemoglobin level can vary from 20 to 30%. Here the diagnosis will be either it could be possible sickle cell homozygous or sickle beta thal or sickle hereditary persistent with fetal hemoglobin also. If a laboratory, if any hematologist or pathologist looking at this chromatogram and the lab, you have a 3 possibility if you do not have any other parameters. So to differentiate between the hemoglobin SS homozygous from sickle beta thalassemia in a Arab Indian haplotype, as I told you, hemoglobin F level can go up to 20 to 30%. No cutoff of hemoglobin level to tell that, well, beyond that level, it is a case of sickle beta thal. If you get a microcytic hyperchromic red cell, persistent splenomegaly, and frequent red cell transfusion requirement, probably it is a case of sickle beta thalassemia as you are dealing with. Because you know the red cell are usually normocytic, normochromic in sickle cell disease unless you have iron deficiency state. So these are the point of features which may favor, but however, either of the possibilities is still possible. However, to confirm it, you have to evaluate both the parents, or you can go for the beta globin gene mutation analysis to differentiate between sickle cell homozygous and sickle beta thalassemia. As I know, the management is essentially same, of course. The standard treatment in the stable conditions, these are all there in the Indian College of Hematology and ICMR National Guideline Sickle Cell Disease, which got released in December 2022. And anybody can take it. I have shared with Professor Agarwal. Anybody interested, he can take it from that entire copy. Everything is there. I will just quickly pass it on. Hydroxyurea should be given in stable condition to all the patients. Folic acid, hydroxychloroquine should be routinely added as it is a chronic hemolytic anemia. Our dehydration, extreme climatic condition, and climatic condition, because that precipitate the vaso-occlusive crisis. Infection prophylaxis to be given from children up to 5th year of age, where these pneumocystic hernia and meningococcal vaccine should be given, and the child should receive all the immunizations as per the schedule. Monitor for the organ damage, and you have to maintain hemoglobin around 7 to 10 gram per cell. 10 gram is upper limit of the maintaining the hemoglobin. If you cross in 10 gram, the benefit will be attenuated by the hyperviscosity, and vaso-occlusive crisis will be aggravated. So these are the principles of management in stable condition. details are mentioned in that guideline also. If there is any standard treatment for the vaso-occlusive crisis, the principle is that it's a very painful, excruciating painful, can be as disturbing as even labor pain also. So my request to my clinicians is that you must address the pain adequately. So adequate pain control should be there. Adequate hydration, infection control, maintain the oxygen saturation more than 95%, prevent acidosis and observe for complications. These are the principles of vaso-occlusive crisis. The management of the vaso-occlusive crisis pain in India is somewhat different from what has been recommended by your American guidelines or by the African guidelines, because of opiates. They use the opiates from the very beginning, left and right. But because of the restrictions and complications, we don't use the opiates routinely. We manage the pain with the tramadol, paracetamol, non-steroidal anti-inflammatory drugs, or diclofenac. The regional anesthesia can be tried if the pain is not reduced. Opiates or buprenorphine patch can be tried if all the first-line, second-line drugs are not effective. Adjuvant therapies like fluid electrolyte, oxygen saturation, other medications should be continued. If it is a resistant recurrent vaso-occlusive crisis, you have to reduce the hemoglobin S less than 30 to 50%. This is the principle of management of pain, vaso-occlusive pain in India, where opioid is used as a second or third line drug reserve. The another important thing is optimal dosing of the hydroxyurea. You have two principles. One is a fixed low dose, 10 to 20 milligram per kg, and second is maximum tolerated dose, where you can go up to 35 milligram per kg. The target you have to monitor with the absolute neutrophil count in between 1.5 to 3,000. So these are the three prospective randomized studies, one from Burla, one of my classmates, and the second is Diptijan from Nagpur, third is from my institute, both pediatric and adult group. And all the three prospective studies have used as a 10 milligram per kg per day fixed dose. And all the three studies have shown that it significantly reduces the vaso-occlusive crisis, reduces the blood transfusion and hospitalization. So 90% of the patients, they can be managed with a low fixed dose, about 10 milligram per kg. However, in 10% cases, if you do not able to control the pain, you can gradually increase the dose of the hydroxyurea. So with these findings, hydroxyurea we recommended at the dose of 10 milligram per kg, where we should always give a low dose. It has a lot of advantage, and that's our guideline also recommended. However, in certain cases, you can increase gradually up to maximum tolerated dose. Benefit of hydroxyurea is a very old terminology, and it has been well accepted, and it has never been discussed nowadays in the recent past. And I will just keep it it reduces the vaso-occlusive crisis both in children and adults. So many studies have shown. It reduces the acute chest syndrome both in children and adults. So many studies have shown. It reduces the blood transfusion. 9 studies have shown that it reduces the requirement of the blood transfusion in children and adults. And there is a reduction in the hospitalization. Again, multiple studies have shown that both in pediatric and adult, it reduces the hospitalization. And for the stroke prevention also, it is beneficial. And it reduces the mortality also. Almost 4 studies, which has extended studies, was the landmark study, MSS study, which proved the hydroxyurea. So it also reduces the mortality. Why I showed you? After the hydroxyurea, which is the most important disease modifying agent, none of the drugs have come forward which can match with hydroxyurea. So far, its multiple benefits is concerned. Now, with all these benefits, do the asymptomatic sickle cell homozygous need treatment? Principle I told that it prevents organ damage, and hydroxyurea may be a toxic drug. Though we don't have any randomized trial based recommendation, but considering that it prevents organ damage is an important feature in sickle cell disease, and our experience with hydroxyurea at low dose is a very safe, effective, and very wonderful drug without any complications. So our guidelines, ICS guidelines, have unanimously recommended that hydroxyurea should be given to all patients of sickle cell and sickle beta thalassemia unless there is contagion. That's the present stand our unanimously we have recommended. So blood transfusion is another important point. So we have in our institution have a prospective study of 208 patients. What we have seen, the patients who require regular transfusion 3 units per year is only 9.1%, and most of the patients have occasional transfusion. If you compare with serum ferritin also, serum ferritin more than 1000 is only 9.1%. Most of the patients are either normal ferritin level also. And if you look at the serum ferritin low also, there can be few patients also where serum ferritin can be low also. So that study shows the red cell transfusion is never a primary therapy for sickle cell disease, nor a secondary. It's a reserve therapy where it can be given. It may be required in 10% of cases when there is a complication. There is a clear-cut indication because it has a lot of complications. Case number 3, female 32 years, school teacher Auricula, sickle cell homozygous with the cholelithiasis. I still remember her name, Payal Singh. She was stable. She had a desire for pregnancy. Hydroxyra was old. Conceived. Aspirin was started 12 weeks of gestation. She delivered a male child with a low with cesarean sections. With the anticoagulants were given after 2 weeks of the patulation. Everything fine, and she got discharged. Again, after a few days back, she come to me, wanted for cholecystomy for intermediate abdominal pain. I purposefully advise and try to avoid, because I know that sickle cell is a high risk complication. Though she has escaped the risk of the pregnancy, I didn't want to take up the responsibility for surgery for that cholelithiasis. I advised to go to other medical college. She came back again to me to be operated at SB Medical College. We prepared with a red cell apheresis with 10 units of the blood. 10 units of was replaced with a normal red cell with extended cross matching, and hemoglobin S was less than 30% at 28%. That's exactly the recommendations how we should go for the surgery. What has happened? Surgery was done day 8. There was a unconjugated. My fear was really whatever I was afraid, it came to be true. On day 8, it was unconjugated hyperbilirubinemia was raised. LDS was too high. Hemoglobin from 12 to 4.2 gram percent. So it was a clear-cut case of a delayed hemolytic transfusion reactions. It's a very serious and disturbing complications in sickle cell disease. The diagnosis of DSCTR is it happens or it occurs 3 to 25 days of the post-transfusion. There occurs darkening of the urine, pain in the abdomen, pain in the body, and worsening of the anemia. The LDS gradually increases and DCT becomes positive also. That can be negative in certain cases, but if you are getting a clinical history and clinical presentation, you are dealing with a case of delayed hemolytic transfusion reactions. It doesn't matter whether DCT is positive or negative. This is a very serious condition. There is a prevention. You have to take the scoring system. For the interest of time, I will skip it. But if you have a really telling that it's a high risk, what the transfusion has to be given, or you have to go for apheresis, you can go for a prophylactic rituximab with methylprednisolone 6 weeks prior to your program. So that's the prophylaxis. Management is that stop further transfusion, because if you give the further transfusion, hemoglobin will further come down. The IVIG is in the standard dose is the treatment choice. High dose erythropoietins and preventive anticoagulation, standard supportive therapy. These are the treatment for the delayed hemolytic transfusion. It's a very, very gloomy conditions, and mortality rate is very, very high. Because the alloimmunization, if you look at the alloimmunization rate, it varies from 11.5 to 16% in sickle cell disease across the globe. It is higher in comparison to thalassemia because of the reasons well explained. But there was in one Odisha study, the incidence of allo antibody has gone up to 44% also. Very, very high comparison with thalassemia, where it is 10% also. We are verifying this data, where we are having our own institution study also will let you know after a few months whether the incidence is really high or is exactly matching with this range also. But whatever may be picture, alloimmunization is very, very high in sickle cell disease. That's a very, very disturbing. So red cell transfusion is never, I told you, never a primary therapy. It has a clear indication. Thus, avoid unjustified red cell transfusion. RBC matching for extended antigen. If you only match ABO-RH match, the allo antibody can go up to 11.5 to 16%. If you go for extended cross matching with all the sub-variety or sub-fraction of the RH KEL, you can reduce the allo antibody productions to 4 to 7%. So that's the recommendation of the transfusion in sickle cell disease. So ABO-RH extended KEL match is the standard. Wherever you are thinking that is a clear-cut indications of transfusion in sickle cell disease. Iron overload, iron chelation. We have another perspective study taking about sickle cell homozygous 208 patients. What we found, serum ferritin more than 1000 nanogram would require transfusion, which is only seen in 9.6%. Paradoxically, serum ferritin low less than 20 is also similarly seen in the equal percent of cases, where if the anemia is disproportionate, you can supplement with the iron so the hemoglobin can be improved. So iron chelation is maybe required in 10% cases. Similarly, iron supplementation may be required in 10% of cases where there is a clear-cut evidence of the iron deficiency. Monitoring is another important point. Monitoring of the sickle cell disease, as you know, as I have told you, it is a chronic disease. There occurs a lot of organ damage. So the monitoring, or it can be done once in a year or once in 6 months. If a patient comes, you have to take care of the acute pain, which is mainly predominantly of the vaso-occlusive crisis. Besides that, also there is a chronic pain also. Sickle cell patients complaints of chronic developing pain, which should not be ignored, should be really dealt with the address, and the patient's life should be made when comfortable. So pain history is very, very important. Second is your evidence of the organ damage. I have told you every organ can be damaged. So investigation should be done for the cardiological evaluations, either ECG, echo, liver function test, your kidney function test, your eye examination, nervous system examination, skin examination. All these systems should be evaluated at least once in a year or once in 6 months. Second, the third entity is your comorbidities. The comorbidity can be broadly two types: is a non-sickle related and sickle related. Non-sickle related is the two important is diabetes and hypertension. So these two common conditions or the comorbidities should be aggressively controlled, because these non-sickle comorbidity can aggravate the sickle and morbidity also. If you do not control the diabetes, hypertension, that aggravates the organ damage due to the sickle cell disease. So essentially, every sickle cell patient should be monitored once in 6 months, 1 year, with painful history, both acute and chronic, organ damage evidence, and accordingly management and control of the comorbidity. So these are the principles on the management or the monitoring of the sickle cell patients. Case number 4 is a 42 years old male sickle cell homozygous. Hospitalized for vaso-occlusive crisis 1 day, fever for 3 days. We manage with standard therapy. No response after 3 days, and pain increase even on day 4. We call it as a resistant vaso-occlusive crisis. The principle is that you have to maintain the hemoglobin around 32 and 50%, and simultaneously not raising the hemoglobin more than 10 gram. I told you, because if you go for more than 10 gram, the viscosity will be increased. So this can be made possible only by the two processes. Either you can go for the normal red cell administration, means you go for the to remove one blood and give one, that's called simple exchange transfusion, or by red cell apheresis. Or you can go for the simple exchange transfusion, means remove 1 unit, add 1 unit normal, thereby going for dilution of the hemoglobin S. But the most efficient way of reducing the hemoglobin S is your red cell apheresis, where you remove the at least 8 to 10 units of the sickle red cells from the patients, thereby simultaneously replace with the normal with extended cross-matching. So that is how you can control the hemoglobin S below that, considered as the most effective way controlling the, say, resistant vaso-occlusive crisis. We have a case series of the 4 patients probably. Benefit of simple exchange transfusion in sickle cell disease with vaso-occlusive crisis not responding to standard therapy. Why I told you this is important? Because going for a red cell apheresis with extended cross-matching may not be feasible in most of the centers. So what we have done in 4 patients, we have only go for a simple exchange transfusion only with the 2, and 1 is 1 unit of transfusion. You remove 1 or 2 and then supplement with another 2 normal red cell. Now, whatever you find out on day 4, every patient after that, the pain was reduced significantly. The most important point is that you look at the hemoglobin S level before transfusion, simple exchange transfusion, and after transfusion. In none of the cases, the hemoglobin S level was less than 150%. There is only marginally reduction of the hemoglobin S around 8 to 12%. So not necessarily that you have to reduce the hemoglobin S level below 50%, which is very challenging to reduce the vaso-occlusive crisis, which are not responding to your standard therapy. I think that hemoglobin S level 50% or 30% should be revisited by a randomized trials in our Indian patients. What is the exact minimum level of hemoglobin S to be reduced? So it can be effective in a resistant vaso-occlusive crisis, simultaneously not raising the possibility of an higher incidence of delayed hemolytic transfusion reactions or allow antibody productions. That's a unmet medical need in our cases. Case number 5, sickle cell disease, homozygous female, 28 years, school teacher, married for 3 years, vaso-occlusive crisis 4 to 6 times 1 year, now asymptomatic after hydroxyurea supportive therapy, got married, and the husband doesn't have hemoglobinopathy. Now the female wants to have a baby. Many ladies are now leading a normal life, leading up to adulthood, getting married, expecting to be to conceive the children also. We have a first prospective Indian study on the outcome, perinatal outcome in sickle cell disease, a prospective study from India, both in combination, in collaboration with the obstetric department and our hematology department. What we have seen, we have taken 60 patients of the sickle cell homozygous with a control arm of 100. So what you found that with the best treatment also, with zero maternal mortality, you can still have a live birth, or you can have a successful pregnancy in 84.4% cases. However, this is a very high risk pregnancy. The complications, the maternal complications, the children complications are much more higher, should be taken up in the tertiary care center where all the facilities are there. The pregnancy is safe and acceptable. I used to call it much more earlier, but nowadays I have seen also with this principle which you followed also, we have lost one few cases also, even during the pregnancy or during the delivery also. So what I request my colleagues that we need to have a standard operating procedures by a randomized study in other institutions to validate what would be the standard process in management of pregnancy. Our guideline has alluded on this aspect also. I hope if anybody wants any details, they can look for our guideline, how to avoid and to minimize. Case number 6 and 7 is my last case. 65 years, female with 5 children. X-ray found that calcified skin, and these are when bone complications. Look, and she was detected first time at the age of the 65 years old. This is not a rare case which I have really given an example. We find quite a good number of cases. They are detected on the 5th decade, 6th decade for some other reason. A high pregnancy, 5 children without knowing that she's having the sickle cell disease. Similarly, these are the family of sickle cell, two brothers, engineering student. Even if I tried my best, this is the younger, this is the elder brother. Even I tried my best. The elder brother first one succumbed for acute chest syndrome. He was staying in Bhubaneswar. I escalated the hydroxyl dose to maximum tolerated dose. After 1.5 years, the younger brother also succumbed to this acute chest syndrome, and I also lost it. So risk prediction is really unpredictable. Though I have enumerated 4 or 5 categories that what are the variables or the factors which can give rise to risk, but in many cases we do not know exactly what could be the outcome. So new approved drugs you have. This is there are many new approved drugs has come. This was the first was come your L-glutamine, which replaces the glutamine. Therefore, the vasoconstriction crisis is reduced. The second come is the voxelotor. It directly inhibits the hemoglobin S polymerization, so the hemoglobin level is increased. The third came with a lot of noise. That inhibits the p-selectin inhibitors that probably inhibits the vasoconstriction crisis. But these 3 drugs, though it is come, the randomized trials was incomplete, information was incomplete, so we are not sure how to use in the best possible way. So new drugs, though promising, but further studies are required for best use, and in Indian trials or Indian haplotype, the trial is very, very insufficient. I will give one example how the new drugs has been planned very poorly, and they are putting it into the Indian continent. I will take an example of the SOSTEN study. So the SOSTEN study, it's a p-selectin inhibitor. I call it as a crizanlizumab, but you have a p-selectin, you have a e-selectin, you have L-selectin also. All the type of selectins, they hamper also, the increases the adhesiveness also. So for the SOSTEN study is concerned, though they presume that p-selectin is there is a hyperactive of the p-selectin is hyperactive, but they have never measured the p-selectin activity, and whatever the drugs has been used, they have never contributed what extent the p-selectin as inhibitor. My second question, what about E-selectin and L-selectin? Out of all the 3 selectin, what is the relative contributions of the pathophysiology in sickle cell disease in a particular community, which has never been addressed in that study also? The second point which I always told that if you look at the study design also, 2 appears to be defective also. Out of 329, they have taken 190, 80 and 131 was excluded. Look at the arm A, arm B, arm C. High dose crizanlizumab, low dose and placebo. In all the arms, they have given hydroxyurea. Hydroxyurea is a non-effective drug in vasoconstriction crisis. They have never able to really discriminate or to eliminate the effect of the hydroxyurea. That's the serious limitations of the short-term study. Whatever the benefit has happened, whether due to hydroxyurea or something else, you cannot tell definitely. So how to go in vaso-occlusive crisis? How to go in 2023? Management should be done, as I told you. The prevention can be done by lifestyle modifications, address to the very specific factors, vaccination for the pediatric age group. Hydroxyurea should be given to all. Though the 3 new drugs are there, who do not have RCT based recommendation, which drugs will be used in what situation. So vaso-occlusive crisis in sickle cell disease, as I told you, is a multifactorial. There are many cells in the circulating blood cells, vascular endothelium, all the cells are hyperactivated. You have a plasma factors also. So many factors that it becomes a hypercoagulable state. So it makes sense that you should go for a combination of the drugs like acute lymphoblastic leukemia, so that to address all the pathophysiology. But there is no research, there is no taker so far the R&D is concerned, because everybody thought that sickle cell is a non-profiting business. So no industry people are coming forward to do any study in combination of the drugs addressing every pathophysiology the way the hematologic malignancy is being treated. So hematopoietic stem cell transplant is the curative option, 93%. You can go for myeloablative, non-myeloablative. Even if you make it an sickle cell trait also, even if chimerism is occurs in 20% cases also, still if you convert even sickle cell major to minor also, still the one patient's benefit is remarkable benefit. The second option is gene therapy. I am sure gene therapy coming in a big way. Whatever the setbacks were there, and it has been corrected. Hopefully, in the next 2 to 3 years, the gene therapy will be a reality. And 2021, 22 belongs to COVID because of the obvious reason, and 2023 belongs to a sickle cell disease. A lot of noise, lot of discussions happening around India, and the most important is the national mission on sickle cell disease launched by the declared by our honorable finance minister, launched by the honorable prime minister a few days back. Also, it has created a lot of buzz around the world. That's the way our finance minister was speaking. Huge budget has been allocated for national sickle cell mission. In compliance with that, our Indian Society of Hematology has come up with the first time in collaboration with ICM with the national guideline management control of sickle cell disease. It has every component for all the stakeholders, starting from policymaker to treating physician to patient groups to NGO. This copy is there with the Professor M.B. Agarwal. Anybody interested, you can share from him. So unmet medical need, I told you the risk prediction is difficult. Infrastructure needs to be upgraded. Train human resources. We know there are many states where the sickle cell patients are managed by physiologists and biochemistry, that we know, even in my sickle cell institute also. So prenatal diagnosis should be available across the country. Genetic diagnosis, bone marrow transplant, of course, gene therapy. Once it becomes a reality, should be available to our patients. So solution for India is a sickle cell disease to the kind of their prevalence magnitude is concerned. It's not a medical problem. It's a social problem. The address would be socio-political revolution, legislation, department of the blood diseases should be there in every state government. National register has been started. I am sure it will be helpful. Social stigma is a huge challenge for sickle cell disease for various reasons. It has to be destigmatized. Infrastructure, human resource augmentation, clinical hematology department should be available in every state of the country. Of course, ICH, ICM national guideline on sickle cell disease is available, should be followed across the state. I think these are things I will skip it to conclude, ladies and gentlemen. Sickle cell disease in India is a mild to moderate severity in most of the cases. Hydroxyurea to all the patients, unless there is a contraindication. Blood transfusion, iron chelation are required only in 10% of cases. The pregnancy is a high risk, can be successful in 84%, but you required a randomized study to really make an SOP which can be recommended. The new approved drugs that are available can be helpful, do not have any randomized trial evidence to recommend how to use in the best possible way. Gene therapy peaks in the horizon. I am sure in 2 to 3 years it's coming to a reality. New agents still are in the pipeline. Prevention by the control is a priority. I am sure the National Sickle Cell Mission will go a long way to control this disease. As I have told you, for a healthy, long, productive life of sickle cell disease, it's a social problem. It cannot be managed only by the medical profession, administration, political will, medical community, industry, our various societies. Social stigma has to be destigmatized, research and development, and moreover, advocacy for this community. The all combination, they can help it also. Why Katapa killed Bahubali? We don't know. It is a mystery. It's probably one of the mystery Why Katapa killed Bahubali? The Bahubali 1 was not able to answer it. Hopefully, Bahubali 2 will answer. But President said, the more the question he wants to know why the Bahubali was killed or the Katapa killed the Bahubali, the more you become wiser and intelligent. And you know, our Honorable CM Odisha had a very big statement. Every life is precious and every state will do everything to save that life. But this man believes something else. This man believes that no real change in the history has ever been achieved by discussions. I don't think there will be another Subhash Chandra Bose who will be born in Cuttack who can go a revolution in 2020 or in 2023. But one thing is certain: for long, healthy, productive life of this sickle cell community, this frame is vacant. The policymakers play a very important role to make this community very, very life healthy. And of course, this society, our society, should join hand with the policymakers. What could be the best possible way for community? Last, I welcome all of you to IMATCon 2023 on the 64, which will be on 2nd to 5th November in 2023 in Hotel Mayfair, Bhubaneswar. There are many, everything is available. More than 500 people have already done registration. There are many out-of-box sessions which will be discussed. I'm sure it will be interesting. On behalf of organizing committee, one, welcome and invitations to attend this conference and make it a huge success. Thank you, sir, very much for your attention. I'd love to be at your disposal, sir.
Thank you, Professor Jaina, for that beautiful presentation and updating us on this disease. Also, a lot of philosophical views which you shared with everybody. May I invite Dr. Sunil Bhatt to start the discussion?
Good afternoon, Dr. Jaina, and thank you very much for an excellent overview of sickle cell. I think you covered most of it in the last 40 minutes. Every aspect has been touched. I'll just start with the basic, couple of questions, and then my colleagues can take over. I think you mentioned it briefly, and I think we do see it in clinical practice, a diagnostic dilemma, because as you mentioned, our HbF levels are a little higher than reported from the African haplotype. So how you in clinical practice, of course, genetic test would differentiate, but in clinical practice, how would you differentiate, a sickle beta versus a homozygous sickle, because some of our patients do have splenomegaly and other things also who are homozygous sickle. So in clinical practice, how do you differentiate them in short of a genetic test, mutation testing? So that was the first question. And the second question I have on hydroxyurea. I think you did mention about the dosing. My question is on, how would you, if you started on 10 milligram per kg, what are the factors and what parameters would you consider in increasing the dose? What are the ceiling dose you can go up to? And would it be directed by the clinical symptomatology or HbF? How would you help us to understand the dosing in hydroxyurea? Thank you.
Okay, thank you, Dr. Sunil. To address your first question, there is no cut-up level of hemoglobin F which can tell definitely, okay, beyond this you are dealing with sickle beta thal. I told you the reasons during my talk also. To differentiate, the red cell, if you look at the red cell morphology in sickle cell disease, it should be normocytic, normochromic, unless there is iron deficiency. But our study have shown that 10% cases there can be iron deficiency also. But if you are getting a microcyte hyperchromic anemia, features of hemolytic anemia, more of a hemolytic anemia, persistent of splenomegaly, though it can be seen in our haplotype also, probably you are dealing with a case of sickle beta thal. It's not an absolutely inclusive or exclusive criteria. You can only differentiate if you do the parental study. If one mother is both the sickle cell trait, you are dealing with the sickle cell homozygous. If one is trait and one is from beta thalassemia trait, probably it was sickle beta thalassemia. That's the way you can differentiate you sort of the genetic diagnosis. And third point, I don't personally feel if you are going for genetic diagnosis, fine. If for intuition gives, it's an academic and going for research. But for clinical practice is concerned, the management is purely essential same. They belong to the same category. Depending on the complications, you have to manage whether the sickle cell homozygous or sickle beta thalassemia. Management remains essential. My second question is that you told me that how you are going to start absolutely 10 milligram per kg. Hydroxyurea is effective in 90% cases, both in pediatric and adult. Even when the baby trial was not available also. We have used extensively, and it's absolutely a wonderful drug. In 10 to 15 per patients, when the pain does not subside or the transfusion requirement is reduced, but not is a completely transfusion independent. In that circumstance only, you have to increase it gradually. You can go for the maximum. There is no parameters that told you that, well, if these features are there, you can go, you can start with a higher dose or you can gradually increase. What depend on your clinical judgment, but at least give a 3 months minimum period to be effective. Then only you can consider that to increase the dose of the hydroxyurea.
Thank you very much. So 3 monthly we can reevaluate, right?
Yes, sir.
So,
Yes, sir. 3 months at least you give a 3 months to 6 months. You can go up to even 6 months to consider that, well, this is not being probably effective. But that is only 10 to 15% cases you have to hike the rate.
Thank you, sir.
And another thing, sir, I will hear also. The mechanism I didn't because of the interest of time. I deleted the slides because 45 minutes was my cap. Sir, if you look at our study also same, nowhere in our hemoglobin F that can will marginally increase 2 to 3%. So rise of the hemoglobin F because of the hydroxyurea is not this one of the mechanisms in sickle cell disease. It's not all. It has a multiple mechanisms. Our 3 studies which I show you, the median rise in the hemoglobin was only 2 to 3%. So hemoglobin rise is not the only criteria or not the only factor to explain the benefit of hydroxyurea. Yes, sir.
Thank you.
Thank you, Sunil. Professor Jena, can I ask you a related question?
Sure, sir.
So, what would be the approach? Is the highest tolerable dose of hydroxyurea most effective, or you have per kg basis the dose and you would not exceed a certain amount even if it is tolerated? Long-term morbidity and mortality, is it connected with the highest dose or some optimum dose?
Sir, so far the vaso-occlusive crisis is concerned, so far the transfusion requirement or the hospitalization is concerned, so 10 milligram, because it's the clinician's judgment, if we go to 10 milligram per kg, it does not, 90% they will be okay. Maybe 10 to 15% you can be able, you need to increase. Your second question, I don't have actually, to be very honest, I don't have any answer, because you have raised a very important point. If you go for the maximum tolerated dose, is that the organ damage will be better with a bit higher dose of the hydroxyurea? Sir, I don't have any experience. I don't have any story to substantiate.
Thank you. From the same token, do you feel hydroxyurea is a replacement for transfusion regimen as primary and secondary prophylaxis to prevent strokes?
Yes, sir. Yes, sir.
It is a replacement with equivalent efficacy. Okay. Dr. Radhika.
Thank you, sir, for the beautiful presentation. Sir, my question is with regards to crizanlizumab. We are one of the centers who are participating in the Ravindra trial, the phase 4 clinical trial on crizanlizumab in SCD patients with VOCs. So I have 14 patients who have been enrolled. I'm on the verge of completing the trial now. My personal perception is that the efficacy of the drug is around 70%, though I have not compiled the data personally. Sir, now I'm working in a government organization, so I stand a chance to request government to include this drug in the NHM. What is your opinion, sir? Is the data sufficient for me to request this drug to be included in the NHM, crizanlizumab? Or should I wait for some time?
Dr. Radhika, you are doing that trial in 14 patients on your own or being supported by the industry?
No, this is a company, Novartis sponsored clinical trial. Sir.
Okay. I was also part to that Novartis supported trial also. I have yet to know a single patient who have taken the drugs in a definite way for a long time. That's I think my things should not be recorded. I think I need a protection from MB sir. The trial which has happened in India, but they are just like I was. I told you so many limitations. They have taken us for granted. They have taken us granted. Tell me honestly, have you given that 14% the dose the way it has been recommended and for a long time to at least 1 year? Tell me honestly, you got that your drugs regularly?
Yes, sir. I had got, sir. I had a real good, like all my patients are pretty compliant. Monthly, they were taking the dose. I completed 13 patients. Only one patient is going to be finished.
Okay. Then you must be exception. But whatever my information goes, they have a very limited. Their supply chain was very much disrupted. They promised they given something 1 month, 2 months, 3 months. Again, they never really supply the way this one. And second thing that I personally feel, since it's a vaso-occlusive type, an Indian haplotype, you should have been more effective. You should have been more effective in reducing vaso-occlusive crisis. But there is no correlation. I have taken my arm without the hydroxyurea arm. I have compared with the hydroxyurea.
No, sir. All my patients were on hydroxyurea.
But that's the point. But how do you tell that this benefit is because of crizanlizumab and this benefits not because of hydroxyurea? I narrated the few limitations of the sustained study also. And you know, for your information, the sustained study which happened in the extended study which happened in Europe also, the result was negative. It didn't really show that benefits. However, there are 4 or 5 studies that are going on which hope will tell you. And the sustained study is not the original study of Novartis. It has been purchased by the Novartis people. So the designing, etc., it was incomplete and it was not that. So on, I don't think if you have any data, please come and present us in Hematcon 2023. We will give you the one platform. And if you really click, there are many policymakers are coming, ministry people are coming, and they will be happy to accept your study design.
I stand a chance of recommending this drug under NHM now. So what is the hematology forum like opine about this?
Madam, please come and present in hematology forum. I think we'll look to the data in details and then we will be able to comment to a certain extent.
Sure, sir. It will be my pleasure, sir. My second question is, sir, when do you recommend exchange transfusion in a VOC case? When
sir, very, I
do you
told
recommend? Because that's not
because I'm very comfortable. I'm very afraid of sickle cell disease because, to be very honestly, because as like I am seeing the complications and etc. As long as without transfusion is there, manage comfortable. You can manage etc. The moment you go something aggressive or something, do as I told you, the best way of reducing the vaso-occlusive crisis resistance, not responding to our conventional therapy, is reduce the hemoglobin S level below 50%. That was the textbook's lesson. But for that, you have to go for the red cell apheresis. You have to use at least 10 units of the red cell you have to remove. You have to go for the extended cross-matching, thereby risking the patient for delayed hemolytic transfusion. So, to what extent you have to reduce the hemoglobin S level? That what is that minimum level without risking the patient for delayed hemolytic transfusion reaction? It's an unmet medical need in our patient.
Yes, because the guideline does not recommend exchange transfusion for a VOC management.
No. I told you, madam, the transfusion is not the primary management of sickle cell, not the secondary. Transfusion is not required for the vaso-occlusive crisis. No, it has to be managed as such. The transfusion has its own indications. It should be avoided. Exchange should be avoided as far as practical.
Thank you, sir.
Thank you, Satish.
Thank you, sir. Thank you, Dr. Gina. Enjoyed your presentation. Made it more interesting with case-based discussion. A couple of questions, sir. Pregnancy with previous bad obstetric history, abortions, or low birth weight babies. How do you manage? Do you do exchange transfusion to keep the HbS less than 50 in the next, not usual pregnancies, but only if they've had a bad obstetric history or low birth weight baby? And before cesarean, do you do exchange transfusion to cut the HbS less than 50?
Sir, after facing a lot of complications, after that first perspective study which I showed you got published, I was very excited. Probably I got the answer. I recommended that pregnancy should be safe and should be done. But I revised my opinion after seeing a lot of complications. And even if we followed it also, we have lost cases also. You know, sir, what if the problem what happens? Similar also surgery. If the vaso-occlusive crisis occurs during the surgery, during the labor, it's a devastating. It is beyond the control of the physicians. That's the way. If it doesn't occur at all, it's fine. We'll go through even without even notice that. If it occurs, devastating and without the beyond the control of any physicians. So my revised goal in pregnancy is that I always recommend to go for the what is that call it? You call it for pregnancy in other way, like with surrogate pregnancy. I recommended to go for surrogate pregnancy or adaptation. Third, if you are still sticking that I should go for the pregnancy, should be on your own risk. Everything should be explained, etc. We'll try our best, but it doesn't mean that always you will be able to protect the baby or the mother. Which was after, if the patient not interested in surrogate pregnancy, adaptation, and still sticking that when pregnancy should be taken up, then he have to go for the pregnancy with his own risk. As I told you, aspirin should be started. Hydroxyurea should be stopped in the initial first 3 months of pregnancy. If the vasopressin crisis is still occurring, I would like to go for the hydroxyurea also after the 3rd month of the pregnancy. Though it is not officially recommended, but there are many studies also they have used hydroxyurea in 2nd and 3rd trimester of pregnancy. It is a safe drug, does not cause any teratogenic effect. I would like to give the hydroxyurea after my 1st trimester if the vasopressin crisis is not manageable with other therapy. Aspirin should be given and low dose molecular heparin should be given before paturation up to 2 weeks. And the surgery has to be managed. You know, there are certain guidelines. You have to do the surgery on an emergency basis. Hemoglobin oxygen saturation level should be more than 95%. Should be done it as quick as possible. Infection should be addressed controlly. Adequate maintain hydration. All these features should be there. But in spite of all the precautions, your fingers are crossed. If that something destiny has to happen, it will happen.
Do you recommend RBC exchange transfusion also?
Sir, for
pregnancies before cesarean.
Sir, to be very fair enough, I am not confident to answer these questions. Rather, I told this is unmet medical need. I will never have any really trial or experience randomized trial. Suppose you have taken it exchange transfusion, reduce the hemoglobin S level, success rate, disabilities with the delayed hemolytic transfusion reactions. This kind of things is not available. But
right.
If you tell me theoretically, then a lot of things can happen. If you can go for rituximab therapy as a proper, if you are considering it is a high risk, the score is more than 14, you can go for rituximab 6 weeks earlier. Then after 6 weeks, one single dose, another dose of rituximab. Go for your exchange transfusion with replacement of the extended cross matching. Hopefully, it should work. But I don't have any experience. I don't have any study from the Indian haplotyping. But this is the recommendation so far the literature is.
Right. So second thing is regarding hydroxyurea. How early have you started? You presented one 2-year-old child where you said you have hydroxyurea. How did you open the tap?
Yes, sir, I got it. But because the another contentious issue, my pediatric colleagues, they don't agree on us. Have you seen, sir, any sickle cell patient coming to any complication and foot vasovagal crisis within, say, 3 months of their life? Certainly not. Very rare, extremely rare. They usually start after 6 months only. The moment they come after that 6 months and etc., you can start the hydroxyurea. Though the tablet or syrup is not available, you can break the capsule and you can give on an average what is the, depending on the weight, it still works. As early as possible, the moment the patient symptoms, you start it.
And any complications you have seen, sir, because you have good data, late complications of hydroxyurea?
Sir, it is a wonderful drug. It's very safe. At 10 milligram per kg, the incidence of cytopenia is so less. You can
like leg ulcers, increased leg ulcers or malignancies post 50, 60.
No, sir, malignancy the kabhi nahi. Leg ulcer does happens in some cases also. Hydroxyurea, suppose a sickle cell patient with leg ulcer come, whether you will give hydroxyurea or not, you have to give hydroxyurea. Though it has been told that hydroxyurea can aggravate also, but you don't have an option. Better accept leg ulcer at the cost of compromising or controlling the vasopressin crisis, transfusion requirement, other complications.
Thank you. Thank you.
So hydroxyurea is such a nice drug at low dose. The cytopenia, the complications, you can completely forget. Extremely uncommon, sir.
Thank you. Thank you, sir.
Thank you, Satish. Dr. Anand Prakash.
Good afternoon, Dr. Jeena, sir. Thank you so much for that comprehensive talk. My question is to do with how do we speak to I'm a pediatric hematologist, and we have young patients walking in who are quite asymptomatic, doing very well on hydroxyurea. But parents always want to know, which does my child need to go for a transplant? Transplant is available in many centers now. We do transplants ourselves, but it's always difficult to decide what would be the long-term organ toxicity outcomes on continuing only on hydroxyurea. In the West, where most of us train in transplant, early transplant is recommended, but that's in a genetically different population where toxicity occurs much higher. Our patients do very well for many years on hydroxyurea. So what should the Indian algorithm be to take up transplant? That's my first question.
Okay, thank you, Dr. Anand. It's a difficult question you have asked because, on the one hand, most of the patients, they can lead a normal, healthy life, marry, can have children with hydroxyurea with supportive therapy. On the other hand, also, I told you the two engineering brothers, it's not a very rare, whatever I give an example, in the case number 6 and 7, these are not rare things. These are very commonly we see that cases also. Sometimes also, in spite of your best effort also, you are not able to control, and there can be sudden death also because of the acute chest symptoms. You don't have any parameter to marker to tell that, well, these features are there, you will be able to, or they are very, very high risks, we should go for the transplant percentage. On the other hand, if the patient is absolutely fine, etc., on hydroxyurea, putting the patients to the transplant program, if there is you have a transplant, have certain TRM, transplant related mortality, some complications, some GVHD, etc. Though the success is very high, even if you make it a chimerism 20%, 30%, still it's good enough. If you can convert from homozygous to even trait also, still the patient is asymptomatic also. On that forum also, there is a challenges also there. I think it has to be discussed with the parents and etc. These are the again unmet medical need in our patients. Who are the patients who are high? What are the markers, parameters for high risk? They are prone for sudden death. They should go for that. So you don't have any answer to that. But if you tell me on a privately on patients, you put having experience such, you could tell okay, you should go for transplant. Yes, sir. You can go for transplant if percentage is good enough. Now, non-myeloablative conditioning regimens are coming up. They are very, very effective. Who can trial? But sir, I don't have any. Again, the city trial-based or information-based recommendation to tell you, okay, this is there, you go for this.
Okay, sir. Thank you. And my second question is that sometimes by the second decade of life, we have adolescents presenting for the first time with established avascular necrosis. I work in Karnataka. We don't have as much of a sickle cell burden as where you work. However, from the border areas of Tamil Nadu and Karnataka, we do see quite a few patients. They are pretty asymptomatic in the first decade, not really picked up by anyone. But in the second decade, they have established avascular necrosis. Any suggestions in that setting? Because our orthopedicians also struggle. We also struggle. Hydroxyurea is obviously started. We do the calcium, vitamin D, supportive care. But what would you suggest for those patients? Thank you.
Dr. Anand, your observation is correct. Because I told you, we have seen quite good number of patients. They don't have any history of the vascular crisis, but they landed to your avascular necrosis crisis or avascular necrosis. They are very crippling. Is really a physical limiting conditions. That happens. That is essentially because we have a subclinical vaso-occlusion in the vasa of supplying the acidabulum also. That is why we told that organ damage is a scenario which has never been studied, which have never been given attention the way the vaso-occlusive crisis or anemia is given. That is the reason our guidelines have strongly recommended hydroxyurea should be given to all the patients, irrespective if there is no contamination. And secondly, what you told that the long-term effects are if you give low dose hydroxyurea, because we hardly only 5% cases to go up to 35, or we can manage with inbutin also. Even we have used 30 years, 40 years. Absolutely the safe drug. Does not cause any problem, any second malignancy or cytopenia, marrow suppressors, nothing like that. So for you to prevent and we have another study also long back, it has been published in Blood also for that avascular necrosis also. If you put hydroxyurea, be it a higher dose, it works. If you have stage 1, stage 2, stage 3 also. If on stage 1, there can be reversibility of avascular necrosis also. If a stage 2 and stage 3, you have to go for the orthopedic massage.
Sure. Thank you, sir. Thank you so much.
Thank you, Dr. Anand Prakash. Dr. Suman Jain.
Yes, sir, Dr. Suman. Welcome, sir. Yes.
Sir, all the questions everyone has asked. I just wanted to know if a patient is having a concomitant alpha thalassemia trait along with the sickle cell homozygous, will the symptoms are less, like a vaso-occlusive crisis will be less if it is having a alpha thalassemia trait?
No. I have shown you that in my picture. It is showing a pendulum from left to right. The hemolytic component will be less. The hemoglobin will be relatively high. The transfusion requirement will be less. But on the same hand, your hyperviscosity percent, complications of the vaso-occlusions will be much more higher. Like avascular necrosis, vaso-occlusive crisis, these things will be completely higher.
So, if I am right, if you understand rightly, if the patients of vaso-occlusive crisis should we test for alpha thalassemia trait, or how to diagnose? Maybe they are.
Dekhiye, ma'am, Dr. Suman, if you are going for alpha thalassemia mutation study, it's a purely academical research way. For management, you don't require. For management, it is the clinician's totality. The clinician will take a call how to manage, how to handle the hemolytic component, the vaso-occlusive crisis. Whether alpha thalassemia is there or not there, management does not differ. You can only know academically as research-wise.
Sir, another question, it is as an observation. One of our patients, at the time of periods, she always complain of epistaxis, nosebleed, epistaxis. She is a clear-cut case of homozygous sickle cell anemia, having lot of vaso-occlusive crisis. Has been given a high dose of hydroxyurea. We have to stop, and she is little bit responding to injection right now, but she always complain of epistaxis during periods.
Okay. So maybe I don't have any idea for that, because it is a hypercoagulable state. Even if it's a hypercoagulable state also, there are certain areas where both bleeding and thrombosis can occur, like your nervous system also, eye vessels, you have a thrombosis also, retinal vessels. And similarly, epistaxis, you are telling it is a epistaxis, I have no idea.
Okay. Thank you, sir.
Thank you. Dr. Sitaram.
Thank you, sir, for the excellent presentation. I have 3 or 4 questions, if I may ask you. I work with Dr. Anand at St. John's in Karnataka. So as Dr. Anand said, we don't see that many sickle cells, but we get from neighboring Karnataka. Nowadays, because of the migration, we see a lot of patients from the central part of India and eastern part of India. What we tend to see is probably the people from central and eastern part of India tend to have more vaso-occlusive crisis compared to one from the south. Is this just a false observation, or is this something which has been looked into? I'm not aware, so that would be helpful. My second question is about penicillin prophylaxis in adults. Is that something would you recommend continuing with the penicillin prophylaxis? My third question is, you mentioned about higher incidence of alloantibodies in the sickle cell patients, but lower incidence in TAL patients. Could you speculate as to why that reason could be? Because we have a homogeneous donor population. And my final question is your views on N-acetylcysteine, because that is relatively easily available to use in sickle cell patients.
Okay, thank you, Dr. So I remember your first and third questions, but if I don't remember any second, third, fourth, so please help me.
Sure,
first question is that your geographical variations in the incidence of the vaso-occlusive crisis, it may happen, it's a coincidental, because while formulating the national guideline on sickle cell disease, we have taken experts from across the country and etc. We have discussed multiple times also. We didn't find wherever we have there, whenever the clinical presentations, others were there, even people from other zones were there also. Nobody really opined that they have seen a different kind of things. However, some pocket variations related to some pocket could be there. I don't have an answer, but essentially, Arab Indian hepatitis remains same so far presentation concerned. And what was your second question then, sir?
Penicillin prophylaxis in
yes,
in adult population.
Now, adult population, we don't. Another thing, infections was considered one of the leading cause of the mortality in the African countries and etc. Based on that, that was a recommendation that in pediatric age group, we should go for the penicillin prophylaxis, pneumococcus, and many other vaccination. But the environment has changed. The rural India has changed significantly. If you belong to rural area, I find there is a lot of changes, a lot of significant changes has occurred in the lifestyle, in the available facilities, the economical food and clothes and etc. are available. Whether that kind of infections which was noticed in the African countries or etc. still is valid in our Indian country or in our country, that needs to be again validated. But however, we give regularly these meningococcal and pneumococcal vaccines, and the penicillin prophylaxis is recommended up to 5 years. Should not be given to the adult because you don't have data to show that if you give a penicillin prophylaxis in an adult, it is really helpful in whatever way. That's the kind of data is not there. Your question number 3, sir?
About the increased allo immunization.
Yes. So that's where it has been all there. Since in Thal measure, you start your transfusion from 6 months to 1 year before the reticular endothelial or immune system is mature. So you have before your immune status is mature, they have been already flooded with so many antigen and things, so the allo-antibody production is normally less. What happens in sickle cell? Since the requirement it does not come in the younger age group, starts in our childhood or adulthood like that, and it's a chronic inflammatory conditions. And third point is that if you look at the red cell polymorphism in the community where the sickle cells there is a lot of polymorphism with the red cell antigenicity. We have more than 250 types of the red cell antigens over the red cell. We only test 3 or 4. If you look at that polymorphism variability in the red cell antigenicity among the sickle cell community is probably highest. So red cell polymorphism highness, chronic inflammatory disease. Third, the sickle cell transfusion starts after your immune system is matured and etc. These are the 3 principal causes which explains the high incidence of allo-antibody. We say thalassemia. Your sir, question number 3rd.
Last question is N-acetylcysteine.
What is that? NS?
And NAC, use of NAC.
NAC means I don't know.
N-acetylcysteine, sir. In one of your slides, along with the crizanlizumab, N-acetylcysteine.
That's L-glutamine and voxelotor. L-glutamine talking.
That is the other thing also, sir. L-glutamine.
L-glutamine. There are 3 new drugs which have been approved. One is L-glutamine. Second is voxelotor. Third is crizanlizumab.
Okay, sir. Thank you, sir. Thank you.
Thank you. We'll take some questions from the audience. So there's one question from Dr. Anand Prakash. Any experience of the group on severity of dengue in sicklers? We recently had a child with HLH who rapidly progressed to modes. So how is the severity of dengue in a patient of sickle cell disease? Is it different?
Sir, I don't have any idea. I don't have any really, because any stressful condition, any infections, anything can aggravate. Dengue may aggravate the sickle cell disease, but how the sickle cell disease is going to aggravate the dengue, that's very, very difficult scenario. I won't be able to tell. But any infection, any stressful condition can aggravate the sickle cell situation.
Thank you. Another question is, do you give prophylactic antibiotics during pregnancy or near the delivery period?
No, sir. We don't give any prophylaxis antibiotic.
Next question is, what are your absolute indication for exchange transfusion?
Yes, if the patient is not responding to your conventional therapy, your vaso-occlusive crisis, even if you have tried to go for a simple exchange transfusion, etc., not responding to anything, So you don't have any options. You have to go for the red cell apheresis or exchange transfusion, taking the risk of certain risks of the delayed hemolytic transfusion reactions, but always go for the extended replacement of the red cell with the extended cross-matching, which I told you.
Next question is about what are your indications for splenectomy in a patient of sickle cell disease?
No indication of splenectomy in sickle cell disease. I have to really find a cause because splenectomy is now extremely less. I think this is not a criteria. But this is not a management of sickle cell disease is concerned.
The second part of the same question is, in a case of splenic sequestration crisis, do you do splenectomy?
No, sir. In so for the splenic sequestration crisis or even hepatic sequestration, same thing, same logic can be applied to the hepatic sequestration crisis. For hepatic sequestration crisis also, you don't go for the hepectomy, or you can go for the you can remove the liver also. So what is there also that? So for any sequestration crisis is there, you have to manage with the red cell support and etc. It's a self-limiting area. It's a self-limiting problem. And once the crisis or once the sequestration crisis improve, you can consider.
Okay. The other question.
Sir, can I give another? Look, if you are telling that, well, there's a recurrent sequestration crisis with a huge splenomegaly that causing hypersplenism, etc. This is a rare situation where you can consider the splenectomy, but you have a lot of other complications also. To go for splenectomy in sickle cell, they are prone for a lot of other complications. Yes, sir.
Thank you. The next question is about hyperhemolytic crisis. How do you manage?
Sir, the same thing is that hyperhemolytic crisis is the continuum of the delayed hemolytic transfusion reactions. I already told you, stop, don't give the transfusion, go for the IVIG, erythropoietin and other supportive therapy can be started.
Again, second part of the question is, are steroids effective?
Not only steroid, the IVIG is the drug of choice. That should be effective.
Is rituximab indicated?
Yes, rituximab is given as a prophylactic. I told you, I showed you that also. Suppose you are considering the high risk cases where if you have a scoring system, if the score is more than 14, means history of the hemolytic transfusion reactions, alloantibody presence is there is acute infective condition. These are the high risk cases. There is a scoring system. If it's more than 14 is there, you have to go for prophylactic rituximab with methylprednisolone 5 mg per kg. And the rituximab is a higher dose, about 1 gram single dose. You have to give 6 weeks earlier. Then at the time of the transfusion, you can give another dose. Rituximab is recommended prophylaxis.
There are two cases described here. One is related to this occurrence of ankle ulcers. You have mentioned that you can continue hydroxyurea therapy, but if each time I start hydroxyurea, patient is developing leg ulcer, will you still continue with hydroxyurea?
So, this is a contentious issue, though it has been proven that hydroxyurea can aggravate some of the leg ulcer. But we have seen also, if you don't give hydroxyurea, it can, besides leg ulcer, it can have other complications also. So my advice will be there, leg ulcer management is a different story. You can take the help of the plastic surgeons and others. That you can have improved the vascularization and skin grafting. There can be recurrence also. These are only part of some patients. We have an issue for that. But I don't think that is an indication where you should stop the hydroxyurea because it has many benefits.
Thank you. The next question is, how do you manage a patient of recurrent priapism?
I think recurrent priapism, it's an issue. If you are not able to manage, even if you're giving an hydroxyurea, etc., you can go for the surgery. There are certain surgery you are recommended by the urologist, and for that you can prevent even priapism also. Hydroxyurea has to be continued in a bit higher dose. That's the case where you have to escalate also. Hydration has to be well maintained, and you can go for even surgical procedures. Rather than going for your adrenergic drugs and other things, I think the urological surgical procedure is much more effective in controlling the recurrent and priapism.
Thank you. The next question is about cortical venous sinus thrombosis. What would be the duration of anticoagulation when a sickle cell patient gets this?
I think that the same principle, if that it has occurred, if there is a spontaneous, it has occurred spontaneously, you have to continue beyond 6 months of the disappearance of the So all your cortical venous sinus thrombosis for disappearance, you have to look for the comorbidity, other predisposing factors like dyslipidemia, diabetes, smoking, alcohol, or everything has to be controlled. Then you can take a chance. If you tell me, sir, what is the any RCT trial based recommendations in that? I don't have any information that. But same principle you can apply for.
Thank you. What are your indications for giving thromboprophylaxis during pregnancy?
I give it. I told you now. I start aspirin from the day one. Once you conceive, I start aspirin, and before I give it the low molecular heparin at least during the delivery till 2 weeks of the postpartum period. That's the recommendation where you go for the thromboprophylaxis.
The next question is: are there any medical complications of sickle cell trait?
Extremely rare, however, they are usually asymptomatic, but in certain situations in high altitude, general anesthesia, etc., they can go for to your so renal infections, renal thrombosis, they can isotonuria. These are the few complications they can have a vasopressor crisis at times when in extreme situations like under general anesthesia, high altitudes like that.
Dr. Tejaswini, your question.
Sir, regarding this National Mission 2023 sickle cell card and other things, can you highlight what are all the things you are aiming to achieve by the national mission? And
look, that sickle cell card, which I was a part of that team also, we discourage because another uniqueness of the sickle cell is that it has a huge social stigma. If you give that any card like that red color, white card, etc., it is going to aggravate the stigma. Same thing has happened. You have also seen the news clipping also when these things was distributed, etc. The tribal population rejected. They told that why you should give a card. Nobody will want a card to mention that I am a sickle cell carrier. The primary cause has to be addressed. The same thing we told that we could really distribute the card, etc. I don't think this is going to be accepted. The best way of destigmatizing the sickle cell is that you have to raise your healthcare facilities. You have made your acceptable to healthcare, very easy and uniform to all the patient groups. If a sickler feels that I can lead a normal life, I can marry, I can have a children without any rider, then only you will declare, yes, I am a sickler, he can carry on any of the cards. But without doing this, simultaneously raising the healthcare facilities, making their life as normal as possible, this is going to aggravate the stigma, not going to any really benefit it.
Thank you, Dr. Tejaswini. Any more questions from Dr. Tejaswini? Problem. One more question is.
Can I ask?
Dr. Radhika, you have a question?
So, in the literature, there is some data, there is some indication of antioxidant nutraceuticals in the management of sickle cell disease. Antioxidant-rich nutraceuticals.
Look, when we are PG students, when we have used a lot of in zinc, there is a lot of postgraduate thesis in the zinc, antioxidant, vitamin E, so many, even vasodilator also. But this has been all faded out in the test of the time because they were not randomized trial based data or studies were there. This was thus came and this also go out also. We don't have any.
Even if somebody has approached us to take up a trial on this, being in an academic institution, can I encourage this trial?
Yes, you can go for a trial. There is always welcome. We have many. I think I will request Professor Agarwal if another meeting. We have so many. I think if you take out this guideline also, we have a chapter in the unmet medical need and what are the proposals we have given on which areas the trial or the studies would go ahead also. So please go through that and you can take up the study also.
But we have never heard of any nutraceuticals in sickle cell disease, sir, in our national guidelines or anywhere like. So
which one? Say again.
In none of our guidelines, in none of our sickle cell guidelines, we have the recommendations or in the management guidelines, we have nutraceuticals. So academically, can I take up these kind of trials which are
No, Dr. Radhika, so far the management as on today is concerned, the national guideline, ICS guideline are clearly very crystal clear. the point which you are raising that antioxidants, other drugs, vitamin E or zinc or whatever vasodilators, because why we have not recommended? There is no randomized trial evidence to recommend for that. But we have clearly mentioned how to manage the vaso-occlusive crisis and other, every component has been dealt with. And you are always welcome to take up the study. No issue. There are many unmet needs. You can take up a lot of areas where we have to go ahead. We have to do our studies also.
Some company has approached us to take up this trial, nutraceuticals in management of SCD. So I was a little skeptical because I never heard about it.
Yes, yes, please go ahead. You can go ahead. You can go ahead.
Thank you. Dr. Kapil Garg.
Yes, sir. So I want to congratulate our guest speaker for the excellent presentation. But I have two comments to make. Number one, he has said that vaccinations are not needed in adult population. But in my view, I think if an adult who has not received meningococcal or pneumococcal vaccine in childhood should be vaccinated by these vaccines. And number two, Dr. Janav is repeatedly saying that we cannot comment upon the clinical trials for prasinezumab because patients are already taking hydroxyurea along with that drug. But if suppose a patient who is having repeated VOCs on hydroxyurea and is not improving, and we add prasinezumab, the child improves a lot. Doesn't it tell something about the effectiveness of new drug?
Okay, Dr. Kapil, thank you. The first thing is that, I have never told that the vaccinations are not given adult. I told the penicillin prophylaxis because penicillin
that is not
prophylaxis is
recommended.
given to. But vaccinations, okay, you can go for it. Again, that's an off-label use. I don't have any. If you tell me which study has shown you that meningococcal, pneumococcal vaccine helps in, what we do give. I do give also. Second thing, so far the year by crizanlizumab is concerned. Look, I do agree. If you ask me that, if you have given for maximum tolerated dose, etc., then you can go for crizanlizumab. Then question will come, why not L-glutamine? And my second question is that these fellows who are doing any trial, they must keep the hydroxyurea aside. You make it an arm and an hydroxyurea arm. You make him a crizanlizumab arm. You make him a combination arm. You make him a placebo. See the difference. That's my point. But however, I agree with you that given the literature informations, if the patient is not responding to the MTD of hydroxyurea, then I should look for the newer options available.
Thank you, Dr. Kapil. Dr. Amit.
Yes, sir. Good afternoon.
Yes, good afternoon, Dr. Amit. How are you? Good.
I'm fine, sir. How are you?
Good, good, good.
Sir, wonderful talk. Again, I'm hearing for the third time, but I learned something new from you always. Sir, I have a patient, 27 years male, who is on hydroxyurea, now trying to conceive. So one day also, if he stops hydroxyurea, it's a problematic for him. So should we stop hydroxyurea if he's trying to conceive? And if yes, how many months before conception? Male child, male boy, male person. Male. Sickle cell disease, male.
Male, then at least it's a very difficult, tricky to tell that at least. Again, you will be, don't ask me the reference. Okay, I am not able to give the reference. But again, there are many studies who have shown that if you continue the hydroxyurea, it does not affect the sperm count or the motility of the sperm in an adverse way. Even if it's affected, the power of the conception really remains there. So hydroxyurea is not a cause of an infertility for that. That study has been published in Blood Journal also. But I could tell that you can go ahead about 2 weeks prior to the conceptions and then you can continue.
So it can be given, no doubt. It's safe to give?
Yes, you can give. Continue. I asked probably a pregnant female. It would have been more tough if she would have a lady. I would have told the same thing if she would have the lady also. Ask her to stop at least 2 to 4 weeks prior to the conception. Manage at least initial 3 months, 12 weeks where there's organogenesis concern. Then you manage after the first trimester, manage with other means. If you're not able to manage, go forward along with the hydroxyurea. But since you are a private practitioner, always take a risk one. Explain in details. Always advise to go for the your surrogate pregnancy adaptations. If she's willing with all the consent, she should take up the pregnancy on her own risk. You have to facilitate and you have to help her. Don't advise that, okay, I'll take the responsibility, I will make it a successful pregnancy. That will be too risky.
Thank you, sir.
Thank you, Amit. I don't see any more questions. If there is any question from anyone present over here, please go ahead. Okay, if none, in that case, well, Professor Jena, thank you very much for being with us and educating us with all your experience, lifetime experience in this disease. Your guidelines that have been published for ICM are wonderful. If you permit, we can put it up on the MHG website, and website has no password. Anybody can access it. So it's just, once you give us a permission, we'll do that. With that, I suppose we call it a day. Have a wonderful time with your family on this Sunday afternoon. And let's meet again on Saturday evening. Bye-bye.